Hello and welcome to your overview lecture on acute kidney injury. Please be sure that you read your assigned chapters in your book and review any of the additional learning resources linked through your course module. So now as we move to collection of subjective and objective data, what are these patients going to look like? Well, that's going to depend on the extent and the nature of the injury. So be sure that you review box 45.1 on page 651 of your text for the major causes and the types of acute kidney injury. It's probably important to note that acute tubular necrosis is the most common cause of acute kidney injury. So the signs and symptoms will depend, as we said, on the nature and the extent of the injury. Your patient probably will feel malaise, they're tired, may have nausea and vomiting, pruritus as metabolic waste products begin to build up in the circulating system. They may have mental status changes. They may become oliguric or anuric. Dyspnea or orthopnea may develop potentially through two different processes. We know that as the pH in the blood changes, the lungs and the kidneys have compensatory mechanisms. Additionally, if the patient has an injury and they've lost blood whether or not you know that they're losing, or blood that you can't see building up maybe in the renal capsule, and then they're going to become anemic, and then they're going to have respiratory changes in response to anemia. So your signs and symptoms will depend on the extent and the nature of the injury. Please look at the different stages of acute kidney injury in your text on page 653. Objectively, you're going to want to make sure that you check vital signs. They're likely to have orthostatic changes. Their skin turgor they may lose suppleness of the skin. They may have generalized edema. You may hear abdominal bruits depending on the nature of the injury. Typically on palpation, you would not expect to be able to palpate a kidney. Caution in the palpation process, but if you're able to palpate a kidney, that's highly suggestive that there's a bleed going on somewhere, particularly if blood is building up inside that renal capsule. That can be problematic. It's going to start compressing on the vital functions, and your patient's going to have some significant sequelae to that. Differential diagnoses are going to be based on any underlying disorders. You're going to want to distinguish between pre, intra, and post-renal azotemia, which azotemia is the building up of nitrogen and metabolic waste products in the blood. Please consider reading the section in the book on page 655 about the range of potential differential diagnoses. Additional objective data you're going to want to get. So on a basic metabolic panel or a comprehensive metabolic panel, quick blood test, you'll be able to look at serum creatinine and BUN. Diagnostic criterion for acute kidney injury is a rise in the creatinine greater than 0.3 milligrams per deciliter within 48 hours after the injury, or the creatinine raises 1.5 times above the patient's baseline within a 7-day period of time. Now, you need to keep in mind muscle mass changes for two populations: the older adult, where muscle mass is naturally declining, and for people who do extensive muscle building. So take those two populations into consideration when you're evaluating creatinine levels. Looking at glomerular filtration rate is a good indicator for you. It's a nice estimation of creatinine clearance. Looking at electrolytes to see if the balance is being maintained. Looking at a urinalysis, does it dip positive for blood? If you have the ability to do clinical microscopy, do you see greater than 3 red blood cells in a high power field, or excessive white blood cells in a high power field, or the presence of any cellular casts, etc. Get a CBC. If your patient is losing blood, you might see the anemia develop. Since one of the etiologies of acute kidney injury could be an infection, you want to look at white blood cells and look at your platelet counts. Other diagnostic testing could include ultrasound. Particularly, you'll be able to see the structure of the kidney and the renal capsule. You'll be able to see if the presence of a hydronephosis and potentially kidney stones. More aggressive diagnostics that you would not be doing, but that could be considered, would be kidney biopsy. And that would be done by a specialist. Please be sure that you review the information on pre, intra, and post-renal azotemia in your textbook. How are you going to manage these folks? Well, you're going to manage based on the underlying cause. If your patient has pre-renal azotemia, then you're going to be considering IV hydration. Perhaps you may need to send your patient for transfusions. If the patient is fluid volume overloaded, you may consider giving diuretics. You're certainly going to want to consider any of the medications that your patient's on, because if you're suspecting acute kidney injury, you don't want them to have any iatrogenic contributions to that with any nephrotoxic medications. So you're going to critically look at any of the medications that your patient's on. You're going to maintain their hemodynamic status as best as possible, monitoring their vital signs as indicators of that. You're going to want to follow these people up minimally in a week. You're going to repeat any of the objective data collection that you did on their first visit when you identified the acute kidney injury, so that you have a comparison now, new data set to compare with your baseline. At their first visit, you're going to follow up in 1, 3, and 6 months, and then annually. Those follow-ups are likely going to include a CMP or a BMP, a CBC, their vital signs, of course, and then you're going to be looking for any signs and symptoms of fluid overload. You're going to monitor for complications. If your patient, after an acute kidney injury, is continuing to have abnormalities observed, particularly in their creatinine, that will be a referral out to a nephrologist. And here are your references for the materials presented. Thank you.